I'll begin then, if you don't mind. I'll say a word of prayer. Let's go ahead. Lord, thank you for this opportunity to be here in this fashion again as parliamentarians, as member of this special select committee to discuss matters around COVID-19 response, so that you may guide us in our deliberations so that we may make decisions that are in the best interest of the country. We ask these mercies in your name. Amen.
Amen.
All right. Are there any apologies for absence? Anybody? Member Golding's position is noted, not that he's absent, but that he may have to leave early, just for the record.
Thank you.
Any apologies for absence? No apologies. Okay. All right. Let me just welcome members and for joining another special select committee to keep under review developments relating to the present public health crisis arising from the spread of the SARS-CoV-2 coronavirus COVID-19. Today is Tuesday, May 19, 2020, and it's now 10 minutes after 10. We're going to move right into it. Very busy day. I know we have Parliament later on and many other things happening. The intention is to cover, as outlined here in the agenda, of course, our regular routine minutes, but in keeping with, well, an update on where we are as it relates to COVID. I'm away.
And prudent for us to have circulated them before this morning, because we're going to have a meeting and at the same time you're asking us to peruse the documents. It's going to be a little difficult in terms of not only the time constraint we have, as you alluded to, but also in terms of the ability to contribute effectively to the discussion. So could we ask that matters such as these be sorted out prior to the meeting for future?
Right. So I circulated them as soon as I got them, which means that I got them only this morning. But I appreciate the point. There's value in that. And with the case of the nursing homes, Ms. Lewis Graham and her team are here, and she will take us through, which I think will be equivalent to us going through on our own, and we can inquire and probe as we see fit. So that's really the agenda.
Chairman,
yes.
May I just make on the prison one, the correctional facilities one, it's
Right.
not a very long document.
Right.
It's just I haven't read it yet because it was just sent, but It's just over 2 pages, 2.5 pages. So it may be something that if we get to it today, we could just read it, read it and discuss it as we read it, kind of thing, section by section, because it's not very long.
That's what I was suggesting when I started, that we could go through it. And if there's a need to ask someone from the correctional services to appear in the future, we could do that, whether the minister or someone else.
Right.
So I want to just start with Ms. Lewis Graham.
With the minutes. Yeah.
Let's go through the minutes. All right, so the minutes are before you, and I will begin with page 1. Doesn't have much there. Page 2.
On page 2, Chairman,
Yes.
below this series of bullet points, there's a paragraph that follows that, a short paragraph, which begins the section of the minutes. Which really should read, and I'm just going to suggest some language. After the word "the," insert the words "discussion and decisions of the meeting."
Remind me where that's again. Sorry.
After the bullet points, the paragraph.
Right. I see that.
Right after the word "the" at the beginning of the sentence, just insert after the word "the" the words "discussion and decisions of the meeting," and then open brackets and say "as reflected in that," and it would just continue section of the minutes, which is there already, and close the bracket after the word "minutes."
Okay.
So it would read "the discussion, the decisions of the meeting," in brackets, "as reflected in that section of the minutes," close bracket, "where the committee lost its quorum were ratified." What we're ratifying is what happened at the meeting.
Yes.
Yeah.
Thank you.
Yes.
All right. Any other matter? Page 2. Page 3.
Minister, on page 3.
Yes.
We look at the penultimate paragraph where it starts. She pointed out that approximately 1,000 persons were recruited to complement the 684 health workers. See the paragraph, the sentence?
Yes.
Yes, could I mean, in light of the fact that there's also a recruitment program that you mentioned, could we ask that recruitment is not technically correct, but for clarity, could be repurposed? Because these are other people in the system, you know?
Right, I got you. Okay. Those persons are repurposed. Okay. All right. So you complement the 6 healthcare workers and over 1,000 additional persons. Okay. All right. Page is 4.
Yes, I mean, sorry, rather than repurposed, we could probably say redeployed. Probably a better word there. She points out that approximately 1,000 persons were redeployed to complement the 684 health workers, and over 1,000 additional persons would be recruited. Just suggesting that.
Redeployed. Yeah, maybe more appropriate. Pages 4. Pages 5. 6. Pages 7.
Chairman, we lost you a while ago, you know. The last thing I heard was page 4.
Oh, okay. I'm now at 7, so let me go to 5, 6, and then 7. Pages 8, 9, 10, 11, 12, and the final page 13. Okay, can I ask that the minutes be confirmed and we move into matters after that? Confirmation.
Chairman.
Thank you very much.
Secondly, subject to that amendment, yeah?
Yes, sir.
The two amendments we made. Yeah.
Right. Thank you, Member Golding, for seconding. All right, any matter arising, bearing in mind, of course, that some of the matters will be discussed substantively with the presentations. The presentations that will come, both on the updates and Dr. Luis Grant and the correctional services.
Minister Chairman, if I can be assured that the matter regarding the infirmaries will be discussed now in terms of the testing protocol and the mobile units, and certainly we could leave that till then.
I don't think Ms. Lewis Graham is going to be able to address that. I got a report that the mobile unit has in fact done testing in one facility so far, or one parish. I think it's one parish. The PS is out of the room now, but the process has started, put it that way. I'll ask him to elaborate on it a little more. I'd ask for a report, but the process has in fact started since we last spoke, in that samples have been collected from at least one institution. Is there any other detail that you would want, or maybe a schedule of going through the entire island, or?
That would help, Minister.
All right, I'll note that, but it has started. I've been reassured that it has started.
On page 5, Minister, a question was asked at the last meeting, which unfortunately the CMO was supposed to have checked on, but did not report by the end of the meeting, as it relates to the transport media kits that were expected to arrive, the 5,000.
Arrived. I think 20,000 has arrived yesterday, so we're in good shape now as it relates to transport. Yeah.
All right, thank you. Page 6, Minister. Member Golden had asked a question about the initial case that triggered the call center number, the cluster. And there was the CMO, I think it was, had indicated that there was a need to do a further check and clarity, and that the matter was asked to be re-examined. Can you say if this has been done?
Brownberg, sorry. I was saying Member
Golding.
Yes, Member Golding. My understanding, and I'll ask her to elaborate. My understanding is that the initial positive case was someone who turned up at a facility, a healthcare facility, with symptoms. You wanted to find out whether or not that could be traced back to some travel history.
Which was the question.
I wasn't really being specific about the first case that emerged. I just wondered if we understood whether that cluster, that call center cluster, whether it originated from an imported case or what. And in the minutes, it indicates that they had done some looking at it, but they weren't yet very satisfied that they had to nail that down and they were going to re-examine it.
Right. So I don't want to second guess the clinical work on the ground without them being present to validate. But let's bear in mind one fundamental principle of this medical emergency or health emergency is that all cases are imported. The issue is tracing back to the original import. So maybe what we'll do is ask the clinicians when they come in to clarify that. All right.
Yeah, I mean, I asked the question in the context of the daily reports we get, which break out the origins of cases between imported cases and other cases and so on. So I was really asking in that context. So I agree that all of it ultimately originates from outside Jamaica.
Okay. All right. Any other matter? Any other matter arising?
On page 11, Minister, you had mentioned the task force was preparing, and I can't remember which of the task forces it is. There's a reference to resilience subcommittee of cabinet and so on, but there's reference to a task force preparing a report. And you had indicated that you wouldn't have an issue with the public health aspects of that document being shared with our committee here. This was to do with how I think how Jamaica is going to move forward. with, reopening and the vulnerable people and so on. So
Right.
I was just wondering whether any further progress has been made on that document.
Right. So the Resilience Committee is appointed by the Ministry of Finance and the Prime Minister as part of the Economic Recovery Program, which I chair that committee, and the work continues. There are some proposed timelines for certain things to be done, which has come up out of an advisory committee that I chair here in the ministry, which has been presented to Cabinet, which is now being the Cabinet subcommittee dealing with COVID. Sorry to sound so confusing, but there are a number of committees that are coordinating this operation. And then it will find its way into the Resilience Subcommittee, which I chair. I want to share it here, but I just want to try and get some agreement or at least understanding around some of the general timelines, because I don't want to confuse the public by putting out timelines that are solely influenced by public health. And then, of course, those timelines have to be adjusted. Members would have heard some timelines announced, including last evening with the decision not to renew the work orders around staying at home when they expire at the end of this month. So that's clearly an indication of trying to move back to normality. But there are others. So what I'm asking for is a little more time to try and refine some of those general dates and then to take them here for a conversation, if member.
Yeah. Yes, Minister. Yes, Chairman.
Chairman.
Yes.
On page 10, you indicate there was a notification that the National Epidemiologist and her team were putting together the modeling for the next 12 months. Could they say the status on that and if it is ready and well we share?
So a modeling was prepared. There are two approaches. There is a risk-based approach where you look at a number of decisions and assess the risks associated with those decisions and mitigate those risks with a series of actions, which we have been doing. And then there's a modeling starting from what was originally done, which was presented around how many people would be affected and so on, and trying to adjust that modeling. Something has been done. Again, it's draft form, and there is an attempt at reviewing and trying to determine how useful it is as a tool for planning. And again, because it's very preliminary, I don't want to telecast it too early because I'm concerned that it may have to change substantially. I'm sorry about appearing to be less than transparent in these matters, but
better word, Minister, would have been evasive, but we understand.
Oh, it's not evasive, not evasive at all. That's one thing nobody can accuse me of. I'm just trying to guide the process in a way that doesn't create either alarm, panic,
No,
or
we understand. We understand.
So, but trust me, we'll find a way. All right. Any other matter arising before I ask Ms. Lewis Graham to go into a presentation? No.
All right.
Thank you very much, Ms. Lewis Graham. Can you just bring your slide up and so that members can follow? And you are supported by Ms. Lewis Graham.
Miss
Brooks. So just introduce her when you're ready to speak. Can everybody see the screen?
But it's on slideshow.
Yes, Minister.
Yes.
Okay. Bring that up for me and then.
Yeah. If I'm not.
Oh, yes. Before Ms. Lewis Graham comes in, member Guy, you had raised a point. I'm surprised that being as meticulous as you are, you did not follow up in the minutes. Matters arising. Read the involvement of private practitioners and the TCC as a requirement being a major obstacle. we have since removed that requirement, and there's going to be another ad placed in the media space this weekend to try to recruit more private practitioners to come on board as part of this process. Just for the record, I just want to just give you that additional information.
Okay. Minister, I'm glad you went to that, because there was a matter in the minutes which unfortunately I didn't check on, which is on page 5, and Member Golin probably you can assist us here. Member Golin added that if service providers such as banks did not have a TCC, was that actually what you said?
No. If
No.
service providers to banks
Exactly.
don't have a TCC, the practice is that there's a withholding that is done from the payment for their services.
That is what I thought. Two.
Yeah. Two. Yeah.
So that's a correction there.
Yes, please. Thank you, Dr. Guy.
I'll ask the recording secretary to just know that. Thank you, members. All right, so Ms. Lewis Graham, just introduce yourself, your title, your colleague with you, and just move right into it.
Good morning, everyone. My name is Cynthia Lewis Graham, Director of Standards and Regulations Division. And with me to share in the presentation today is Ms. Renee Brooks. She is a Registrar for Health Institutions and Facilities, which is a unit under the Standards and Regulations Division. So I'll just go straight into the presentation where we're going to be looking at nursing homes regulations and to some extent as it relates to the context regarding COVID-19 outbreak. So we are looking at the fact that nursing homes are regulated under the Nursing Homes Registration Act and the regulations of 1934. Just to mention that the act was amended in 2002 to make more robust the registration procedures as well as the definitions. And in 2004 to look more so at the fees that are charged and the actual fee, charges for sanctions under the act. So we saw some increases in fees during that time. Just to indicate that the definition of a nursing home under the Act is restrictive, it says any premises used or intended to be used for the reception of and the providing of nursing for persons suffering from any sickness, injury, or infirmity, and includes a maternity home. That goes on to indicate also that public hospitals and psychiatric facilities are not included facilities that are regulated under the Ministry of Local Government. The types of homes that would be covered based on this definition would be the convalescence homes, the maternity homes, private treatment centers, and medical surgical centers. And these would have been housing patients over a 24-hour period. Now, as it relates to the facilities that we have identified through surveys and through our work, we have recognized that there are various other types of facilities. And so we have...
If I may here, could you go back over the point about the facilities on the homes run by the Ministry of Local Government?
The homes run by Ministry of Local Government would be those that are classified as infirmaries. They are not covered under this bit of legislation. Okay. This bit of legislation only speaks to private entities.
Okay.
So under the circumstances, we do some inspections and some monitoring visits in the infirmaries, but they are not on our register.
Are persons in infirmaries sick or just old and infirm?
Both. Okay. And we find that situation in most of the homes that we are regulating in the private facilities as well. So what we have done is we have identified, as we said just now, some other services that are being provided, and we recognize that we have under our jurisdiction at this time also homes that are being used to house persons with disabilities, persons that have retired, and persons that simply need assisted living care. So under those circumstances, the latter three homes just mentioned are not necessarily covered under the Act, and we do monitoring visits for these facilities.
So just to understand one thing, a private hospital like, Andrews Memorial or Medical Associates or St. Joseph's before it was whatever it is now, are those types of private hospitals included?
Under the circumstances, when we started our responsibilities under the Nursing Homes Act, the hospitals were not covered. But then we sought instructions from the Attorney General's chambers, and in 2010, we were given a guidance document to indicate that based on the definition that we have of nursing homes, that the private hospitals could be regulated under the Act as well. And so when that guidance was provided to us, we moved to put in provisions to be able to manage these facilities.
So
prior
do
to
you
that,
currently,
sorry.
you register them currently then, when
So
they apply?
Currently, we register them. The process that they should be following really is that they should be applying. However, the Act also gives us some authority to go into facilities that we may think are operating as nursing homes. We have been working very closely with all the private hospitals to get them to comply in terms of submitting an application, because we need to know what exactly it is that they would have been providing as service, which the application provides us with. Until we really have that application, going into that home would be going in blindly, or going into the hospital would be going in blindly. And so therefore we may not meet our objectives for going in.
Prior to 2010, how were these private hospitals monitored, registered, or regulated?
Well, the Standards and Regulations Division was established in 1999. Prior to that, the hospitals would have been regulated on the clinical aspects of the Ministry of Health. So based on the structure that we have now.
When one considers home, you don't really think of something like a private hospital.
A private hospital. So what
surgery and all that. Mm-hmm.
So what obtains, Mr. Minister, is that we in 2002 through to 2005, we moved to make a recommendation and did develop a recommended bill for the amendment of the Nursing Homes Act for it to be renamed to Health Facilities Registration, and also for it now to include more precise regulations for the facilities. So we would have regulations that would be speaking specifically to hospitals, and then we would put in regulations for any other of the facilities that we would have identified throughout our work schedule that we recognize as facilities that would have been under the Act.
But that bill hasn't gone forward.
No, the bill started before my time, and is still under review. But I have insisted that it be given some attention. The truth is, our legislative agenda has not been what I would like it to be, and you know, it's a general statement. I don't think it's confined to my own stewardship or this administration, but I think with all that is happening now, it forces the need for us to improve on that, and I'm making some special arrangements to try and get that done. But members, can you allow her to just complete the presentation and then you ask the questions, because I think you're breaking her run up to the crease. You don't mind, if you don't mind. Jot down the questions and then ask after. Go ahead.
Okay, so just to continue, one of the critical role and function that we carry out in the regulation of nursing homes is that of registration of the facilities, and this is governed by Section 3 and 4 of the Act. Under the Act, there's a requirement for the establishment of a nurse registration committee, which is a multidisciplinary, multi-agency committee. That committee has been in place since we started registrations in 2005. We also develop guidelines and inspections tools against the Act so that we'll be able to function in a more precise method. And the guideline document was initially published in 2002, and of course it has been amended subsequent to that, and has been made available to the public because it is actually published on the Ministry of Health's website. The Health Institution Facilities Unit was introduced in 1999 and was given the mandate to carry out the regulation of nursing homes. And of course, we had to start from scratch to get everything in place because the regulation that was there was inadequate, and so that is why we had to get the amendment done in 2002 and moving forward. Just to say that the the unit is responsible for carrying out the inspections and to maintain a register of all the registered facilities and to conduct training and public education activities. Those are the major roles and functions. And just to indicate that the Act indicates that we need to gazette all the registered homes and so on an annual basis. The recommendation is made for the homes to be gazetted and is submitted to our supervisors. Just to mention a little bit about the process, because we want to let you know that the process is very, what I would say, straightforward. The applicant needs to submit an application on a form that is issued by the Ministry of Health, supported by documents such as the layout of the facility, the ownership of the facility. They also need to provide us with information regarding change of use or no objection to the use of the property by the municipal corporation. They also need to provide us with inspection report from the public health department. And so all of that comes in as a submission for application for consideration for registration as a nursing home. And they pay a fee for the registration, and this is based on the bed capacity. So facilities that have 25 beds and less would pay a fee of $5,000, and above 25, $10,000. Upon the submission of the registration application, an assessment is done, and then an registration inspection is carried out by a multidisciplinary team. We look at nursing care, documentation, staffing, infection control measures, and operating procedures, documents, etc. when that inspection is carried out, and the findings are presented to the nursing home registration along with the other documents for the recommendations to be made. Now, at the end of that deliberation, the committee can make one of four recommendations. One, that the facility is considered satisfactory and can be registered. Two, unsatisfactory, and therefore further work needs to be done to bring them up to a satisfactory standard. Three, that based on the information submitted, the facility cannot be considered for a nursing home registration. Or four, if it was a pre-existing nursing home, the possibility of closure could also be made. Then we look at the fact that the certification for the home is 2 years. So after each 2 years, they need to apply for re-registration. And if they make any change in the business scope, they need to notify the ministry, and this can result in deregistration depending on the extent of the change. And of course, the team is responsible for monitoring to ensure that the facility maintains the standard against which they were registered. Now, just to share a little bit with us as it relates to the status of our homes, on our records, currently we have 187 homes, and of course that there may be more out there that we don't know of, because we are very aware that persons are actually using opportunities now to establish businesses, and sometimes they don't notify us that they're opening these homes, and it's while we're doing inspections in certain parishes and so on that we may identify homes, or persons may call in to let us know that some home has been established. Now, the number of applications that we received over the period 2018 to 2019 is 98, and of that, we had 38 new applicants. Just to look back over a period of time in terms of 10 years ago, we actually had 113 homes registered over the 10-year period. And then the numbers of homes requiring new homes requiring registration during this period, which is up to now, is 40. And the number of homes not requiring registration, we mentioned earlier, those that would have been assisted living or retirement homes, are 8. And the number of homes not registered within the last 10 years have been 52. Just to continue to indicate that for current registrations, which means that their registration is within the 2-year timeline, we have 35. We have homes being processed for registration, which means that they would have submitted their application, and we are working based on the recommendations of the registration committee to make sure that they meet the standards. And then we have some homes that we have issued warning letters regarding their non-compliance issues. Just to mention also that with all those homes that we would have issued warning letters, we have received information that 16 of those homes have closed subsequently.
Can you go back to that slide for me? Because there seemed to be a discrepancy which could need some clarification. Previous slide.
Yes.
The number of applications received 2018 and 2019, new, you have 38. And then you said over the past 10 years, number of new homes requiring registration is 14. Can you explain that to me?
Okay, so 2018, 2019, we would have received applications, but during the 2018, 2019 process, some of these, and they would have been registered and would have been included in the 130.
No, I understand that, but the number of new homes requiring registration was only 14. So you're saying that's only 14 of that 38?
Only 14 of that 38 that we are now working with. Some of them have not been visited as yet since their submission of application. Some of them would have received one visit, yes.
And that's for 2018, 2019?
The 14 would more so be in the 2019 period.
Now, you see, I understand all of that, but does that mean, therefore, you said this is over the past 10 years?
10 years, yes.
Yes. So you're saying that only 14 homes?
No.
Past 10 years?
Yes, go ahead.
14 homes were new homes requiring registration within the past 10 years?
No, let me just explain. The number of homes registered within the last 10 years, as is indicated, there is 113. And this is that caption now in terms of number of new homes requiring registration would have been those that are not yet registered out of the 8 that we would have had submitted for 2018, 2019.
Okay. Thank you.
Okay. Wow.
Go ahead.
Yes. Okay, so we basically are going to be looking now at our COVID response with regards to these nursing homes, and we would have indicated that there are some guidelines that we would have issued based on the act, as well as looking at various standards that have been established locally for building structures, and so on, regarding the layout of the facilities, the space, the size of the rooms, the size of the space between beds, and so on. What we find is that there could be a risk as it relates to a COVID outbreak of an infection developing and spreading in those homes based on what would be considered crowding. And then that would result in us having a difficulty in implementing social distancing. This has to do with the sharing of common space, because we have more than one person in a room based on the standard that was established. They share restrooms, they share recreational area, and so given the nature and the size of the homes and the number of the persons who are there, the number of residents, then have a challenge with crowding. However, our team is working closely with the homes to manage such. Some of the recommendations that have been made is that, for example, they don't have persons eating in one common area. If you cannot maintain that social distancing, maybe they should be served their meals in their rooms. The scenario also as it relates to the recreational space, they would have to now look at how they designed their recreational activities to ensure that they do not have overcrowding occurring in those areas. Then there's the possibility of improper handling of laundry. How is it that they handle what would have been considered medical laundry versus general laundry that has to be separated and handled differently? How is it that they handle medical waste and food preparation? Those are issues that could be a risk in terms of the spread. Then we also look at the risk as it relates to the overall infection prevention and control strategies and the measures that are in there that could be negatively impacted by resources, because some of our inspections have shown that some of the homes are within areas that have challenges with water, with piped water. So we could have a challenge as it relates to water shortages in some of those facilities, which would negatively impact the infection control measures. Strategies that we have put in place so far and will continue to work with to monitor is that we have developed and we have issued COVID-19 specific guidelines and protocols to these homes. We have currently on the ground our public health inspectors and public health nurses who in the regional health authorities who have conducted inspections since March through to now, up until now. So we have a report on that. We intend to do virtual training with the nursing home proprietors, and that is going to be done by the registration unit here in the Ministry of Health. We have been working with the nursing homes through the public health inspections that have been carried out to identify isolation areas in the facility. Should there be a need, if there's a suspect case, that the person should be isolated from the rest of the residents. and what action they need to take if such a situation develops. There is also situations where homes are, more than one homes are owned by one proprietor. At the end of the day, an agreement can be had where they look at bed space availability in the other locations and transfer some of the patients there, some of the inmates there and residents there, sorry. And then you have the situation where they could identify potential patients that could be discharged home for a period of time. So those are strategies that we are proposing to implement through the COVID outbreak period. Then we are looking also at the fact that our inspection team is on the ground. They have been doing, in some situation, once weekly inspections. In some situation, they inspect 2 times per week. So the multidisciplinary inspection team includes our public health inspectors, our public health nurses, our registrar of health facilities, also as a participant in that inspection. And we have our monitoring officer and our pharmacist who looks at the medication administration in the facilities. So far, since March 2020, we have gotten in the reports regarding the inspection carried out. There are 3 parishes that we are still awaiting the reports from, but so far we have conducted inspections of total of 118 facilities. 85 of these facilities have been found to be satisfactory, which means they have implemented COVID infection prevention and control strategies. 33 are unsatisfactory. Some of them would have included those that are having the water shortage situations. And so we continue to work with these, and we'll be monitoring those that are unsatisfactory very closely, and to implement whatever other public health strategies that we have in place to help with these, to curtail any outbreak. As it relates to the private hospitals that we spoke to earlier, we recognize that we started regulating same under the Act in 2010, and a total of 16 hospitals are on our record. Total applications that we have received for registration from the facilities, 10 facilities have applied. Currently, we have 4 facilities on our record as registered with a 2-year duration, but previously 5 were registered. 1 had the registration expired in February of this year. So that application is in, and we are actually doing the inspection to re-register that facility. The total facilities that been processed for registration, 6, and when we recognize the need, given the fact that we now have a crisis, that we need to know the status of all the facilities. They provide major support to the Ministry of Health in terms of providing healthcare. We decided that we needed to do 9 inspections, and we have scheduled inspections which started May 11th, and we will continue through to June. So as it relates to outbreak in the nursing homes, we will mobilize our inspection team as indicated before. We will we have moved to establish a special task force that is going to be looking at the revision of the protocols and the guidelines that we have to make them more COVID specific in terms of the response. And should there be a suspect case of COVID, then it will now trigger the public health response, which means that the homes will now have to implement the communication plan that was provided them, which means they need to report same to the local health department and also their attending physician and await the response from the public health department. They need to implement and tighten their infection control plans to put the suspected case into isolation, start implementing the use of the PPE for these patients, and to transfer to health facility based on the MOHW policy. When we contemplate the roles and functions of the Ministry of Health, the Standards and Regulations Division in the regulation of the homes, we recognize that we are supported through legislations and policies and guidelines in the work that we do. We have the opportunity. We are in a situation where we are collaborating with the other aspects, the other divisions in the ministry, as well as the regional health authorities in carrying out our roles and functions. And we also collaborate with other ministries, like Fire Brigade, the Municipal Corporation, Nursing Association, the Consumer Affairs, because we even do public education activities through the Consumer Affairs Division. Now, our weaknesses, we recognize we have resource constraints because the unit was established in in 1999. The number of homes and the types of homes have grown since, but we have not seen the increase in the human resource in the unit. And so we are working with the organizational structure review to correct that. We have weak enforcement possibilities. We would have spoken to the fact that the scope of the regulation does not allow for more action to be taken. And we have recommended the amendment or the revision of the act, and we recognize the slow pace with which this is being carried through. Now we're looking at the fact that opportunities are there for us when we can move to, as Minister Tufton just indicated, to ensure that we move swiftly to have the amended regulation put in place, to, as we said just now, do the organizational structure review and revision, revise the development of guidelines, and to do further collaborations with other ministries to look at the protection of senior citizens and to increase our public education activities. Of course, there are always those will be unwilling to comply with legislations. And under those circumstances, it means that we have to increase the number of visits. We have to increase our enforcement capabilities. And so those are the actions that we are planning to take moving forward. Thank you.
Okay, thank you very much, Ms. Lewis Graham. Members, the presentation is before you for comments or questions at this point in time.
Chairman, just
Okay.
indicate my apology if I have to step out just to deal with how inspections done.
Member Malawi Fort, your reception is very poor. We're not hearing you.
The list of nurse.
Member Malawi Fort, your sound is extremely poor. Didn't hear anything that you said earlier, to be honest, except an apology.
Let me see if I can have that remedied, Chairman. Just give me a few.
Okay, great. Member Brown Burke, I recognize you.
Okay, so just a few questions for clarification, Minister. The 9 visits that are contemplated, it is 9 visits in all, I'm assuming, not that it's 9 visits to be made to cover all the nursing homes and facilities that are there, just for clarification.
The slide that spoke to the 9 visits was specifically speaking to the private hospitals. All the nursing homes are being visited on a weekly or 2-weekly basis by the regional health authorities. We have an association with we work closely with the public health department. So either the public health inspectors or the public health nurses are conducting inspections of those facilities on a more frequent basis.
Oh, so it's 9 for each? Is that what you're saying? 9 for each institution?
No, 9 is 9. We have scheduled 9 visits now, and it is going to be for 9 institutions, for 9 public hospitals, private hospitals. Sorry.
No, understood. Okay, the other question that I have, you spoke about training for the proprietors. Is it because the proprietors are all administrators, or is it that you are also going to be including training for the administrators?
Okay, that is a very good question, because the training that we conduct.
Member Norman Dunn, can you mute your mic? Member Norman Dunn, can you mute your mic, please? Mute your mic, please. Member Dunn. Thank you.
Okay, so the training that we conduct, and this is something that we do once per quarter, really, in terms of training of the nursing home staff. I mentioned proprietors, so I just want to correct that to say that we will be training the relevant staff, and in particular those that are actually involved in the care of the resident. So it is going to be something that will therefore mean that all the nursing staff and all the staff giving support in the nursing homes can be included on the Zoom meeting when we do that training.
Oh, okay, that's understood. When you spoke of the issue of water and a couple of the institutions that are in areas that also have a water problem, I wasn't so sure if you had given them a mitigation plan for that.
Yes.
Or that is just that you did. Okay.
Just to say that with regards to the inspections that we carry out, there are certain aspects of the inspections that are actually the responsibility of the public health department. And so the public health department, having gone in and identified the issue with water and any other aspect of sanitation, etc., has provided mandate. So most of these facilities would have tanks in place. And what the public health department does is that they give them a mandate, they give them a timeline, and they go back in and inspect and implement the recommendations.
Okay. The other question, Member Brownberg?
For now, I think this is the beginning. After a while, I mean, we see the ones that are unsatisfactory. So I mean, that is something that we want to probably be able to track and to follow, so that we know that persons are in fact carrying out the instructions or the recommendations from the team to protect individuals who are there. I also believe that it's important for everyone to know, not just administrators, not just the workers, not just the residents who are there, but their families too, so that they can help in making sure that these standards are maintained.
Yes, the entire approach is that we have given the facilities what we call the COVID-19 related procedures, and one of that includes the development of a communication plan. A communication plan includes the provision of information to both their to their staff, to their persons who are resident in the homes, and to the relatives and to the community. So under the circumstances, once they implement that, whatever communication, because for example, as it relates to visiting, the relatives would definitely have to know whether that if visiting is allowed and how visiting is to be conducted, etc. So communication plans are in place, and they just need to implement same. So we'll monitor to ensure that they implement same.
Thank you, Member Brownberg. I see Member Holness's hand up. Member Juliet Holness, go ahead.
Can you hear me?
Yes, very well.
Quick question. Do you do spot audits of the facilities? I actually wondered about family members and whether or not we literally just dropped in from time to time to ensure that they are following the protocols at the respective homes.
I will have my registrar of health facility respond to that question.
Go ahead.
Good morning, everyone. Well, we do two types of inspections at our facilities, both announced and unannounced. So we will have inspections that are scheduled. So facilities will get time to put anything in place that is not where it is supposed to be. However, we are aware that there are times when things may fall off of form. So we do unannounced inspections from time to time.
Is that sufficient, Member?
I would want to see them being able to give us an
inventory.
Okay, we lost you there.
I'm saying it would be good that in future reports we get an idea as to the number of spot audits that are done in facilities of this nature.
Thank you very much.
Are prepared, it's a significantly different story than if you drop in and see exactly what is taking place.
Right. So I'm going to just say, well, let's see, Member Guy has his hand up. Go ahead, Member Guy.
Thank you very much, Minister. Just a quick question. What is the staff complement of the unit?
Currently, 2 members of staff. However, their role and functions are supported by a multidisciplinary team that is co-opted from the regional health authority. So, for example, when we do an inspection of a specialized facility such as an hospital, we co-opt medical surgical specialists. We co-opt persons who are expert in laboratory or X-ray facilities. We co-opt microbiologists. The public health inspectors are from the regions. Whatever other specialists we have, depending on the service that the facility is offering, that expecting, we co-opt members of the team from the other aspects of the Ministry of Health. But we only have 2 members of staff in the health facilities unit at this time: the registrar for health facilities and a monitoring officer.
And in the standards branch?
In the standards and regulations division itself, we have, in terms of technical members of staff, 21. And we actually have three different units, departments within the division. And of course, each department supports the unit as well.
Okay. Thank you.
Okay. All right. So I don't see any other hand up. I wanted to just say quickly that, just in summary, because we have 2 other critical areas to go into, that I'm going to ask the team at Standards to, in another couple of weeks, given that you have now presented a sort of situation analysis of where we are and what we're doing, in another few weeks, maybe you could just submit a 1 page or 2 pages just to give an update, and I'll just circulate it to the committee as opposed to having them appear again, unless there's something that requires their appearance, so that the committee can be kept updated as was requested, and I think with value, by Member Brownberg. So it's maybe every 2 weeks or so, you just submit a 1 page or a 2 pager to say, okay, this is where we are, this is what is happening, and if there's anything outstanding that requires elaboration, then you can do that. If members are agreed to that, then I think
Agreed.
have a basis to proceed. All right. Member Brownberg, you look like you're in some foreign country there, man. The background looks very
The technology, sir.
Careful of COVID wherever you are. All right. So thank you very much, Ms. Lewis Graham and your team. Appreciate the time and the effort. So we wanted to now go into the I should also say for the record, just for emphasis, that the team has been mandated not just to monitor and assess registered nursing homes. Even though we want all nursing homes to be registered, given the situation that exists now with the public health concerns, we are as strong as our weakest link. And as a consequence, I've asked them to assess for COVID resilience and response all facilities that are conducting their affairs as a nursing home. And I think that is important, and because of the potential risk that could be there if they go unmonitored. So thank you very much, I appreciate it. Have you brought up your, so we have Dr. Wellington, who is part of the team, the epidemiology unit, and she's going to give the quick status update on COVID to date, and of course, after which we can raise our regular concerns or questions. And then if time allows, members, I would run through quickly the prisons or the correctional service, or would you like me to do that now? While you're up already? You're on the screen?
No, not quite yet. I was about to share screen.
Okay, she's about to share screen. All right, go ahead. I think that's important. Okay, thank you.
Right. Hi, good morning.
Can you minimize over there? That's it.
Okay.
Are you seeing the screen, members?
We are.
Where?
Okay, great. All right, go ahead.
All right. Good morning, everyone. As at yesterday, and the situation. Oh, okay. My name is Dr. Ayana Wellington. I'm a medical epidemiologist. I'm the medical epidemiologist responsible for communicable disease surveillance at the Ministry of Health and Wellness. Right. So as at yesterday at 3 p.m., May 18, 3 p.m., the date on this is, we're saying as at May 17th, but we actually have an update for some of the figures. We had 520 confirmed COVID-19 cases overall. And you can see the parish distribution of the cases, with St. Catherine having the largest number of cases at 25, followed by Kingston and St. Andrew at 119. The breakdown of the cases was 44 imported, 24 were local transmission not epidemiologically linked, 201 were contacts of a confirmed case. However, that number increased to 204 as at yesterday. The number of persons who were under investigation was 251, and 321 those who have died. There are a total of 437, or there were a total of 437 persons in isolation, and 324 were in quarantine, distributed as noted in the pie chart. This is our epidemic curve, which gives the number of cases by have trended downwards since then. This is a cumulative number of confirmed cases, and as you can see, we are tracking at what we did was remove the workplace cluster, the aforementioned workplace cluster, and when we did that, you can see that we're tracking at I think it's 9-day doubling, well, less than 9-day doubling. The reproductive rate remains at 1.6 for secondary cases. This is a distribution of cases per 100,000 population. I mentioned before that the parish with the highest number of cases was St. Catherine, but the parish with it is also the parish with the highest rate. So the number of cases according to the actual population size, followed by Kingston and St. Andrew, followed by St. Mary. Overall for Jamaica, the rate of cases per 100,000 population is 19.1. Some map showing the distribution of cases by community. There's a table later on that shows the actual names of the communities. And this is a comparison of the distribution of cases by community 2 weeks prior and as at May 17. So the changes can be noted in concentration. This is a close-up of the workplace cluster, and you can see that most of the cases, they were from Linstead and Old Harbor communities. And this is borne out by the actual, this is a table that supports the preceding map. This is a concentration of cases overall by community in St. Catherine, with the red areas being the highest number of cases in a given community. And this is a breakdown by, this is a table that shows the same distribution. So the top 5 communities in St. Catherine would be Linstead, Old Harbor, Portmore, Greater Portmore, Waterford, and Ensom, Spanish Town. KSA, the communities with the largest number of cases would be Constant Spring, Dela Creek, Penn, Bull Bay, then we have Olympic Gardens, Lawrence Tavern, etc. In Clarendon, Hayes was the community with the largest number of cases, and that is borne out by this table. Manchester, the northernmost part of Manchester, specifically Christiana, showed the largest number of cases. And for St. Mary, the communities that border with Portland are communities that have the largest number of cases. This is a distribution for St. Anne with the Ocho Rios community showing the largest number of cases. As far as the situation is concerned, so that's the geographic distribution, the clinical status of persons, the number of recoveries is increasing, and the number of deaths has remained the same for quite some time. The So this is the distribution of recoveries by age group. The clinical status of patients as described as distributed by geography. So most of the deaths, for example, were persons with a KSA address. Most of the recoveries were from St. Catherine and KSA. As far as the persons who require hospitalization are concerned, we had 11 critically ill persons overall, 10 moderately ill, and this is the age sex distribution. For the critically ill, the males predominated. As far as the moderate critically ill persons by parish distribution, for both moderately and critically ill, St. Catherine and KSA accounted for most of the cases. So far, the parish health departments have been investigating all confirmed cases. Contacts are identified, and their contacts are also identified. We have traced a total of 3,729, actually, contacts of confirmed cases as at yesterday afternoon. And there have been 424 cases that were identified as a result of contact tracing. As far as the clusters, this map shows the clusters of cases with the BPO complex noted in red or pink, predominantly in St. Catherine. The age distribution of cases overall for Jamaica shows most cases in the 20 to 29-year age group. However, this has been influenced by the presence of the workplace cluster, which has most persons in that age group. We've had more females than males overall, and I mentioned the parish distribution already. As far as the symptoms are concerned, most persons present with fever or cough. This is another way of showing that. Hypertension and diabetes are the major comorbidities that we have seen. Of the deaths, all of the deaths had a comorbidity and a comorbid condition, with cardiovascular disease and diabetes being the main conditions that were seen among the 9 deaths. I've identified 43 confirmed COVID-19 cases through respiratory surveillance. So this is our routine surveillance system. The largest number of cases had onset in week 16 of 2020. And the number of cases identified since then has fallen. The most cases identified through our routine surveillance were from Kingston and St. Andrew and from St. Catherine. So our inferences based on the data I've analyzed is that the number of COVID-19 cases related to clusters, unrelated clusters, is increasing. We have identified cases from all parishes except for Hanover. The number of cases identified through our respiratory surveillance, this is our routine system, has generally increased since mid-March. Community transmission is imminent or present in Jamaica based on the first inference. And our case investigation and contact tracing, while it's extremely labor intensive and tiring, is critical because we have identified quite a large proportion of our cases through this method, and it's essential for containing and managing the spread of COVID-19. Thank you.
Thank you very much, Dr. Wellington. Members, this is a presentation as representing the most current updates. I mean, situation unfolds on an ongoing basis. Can you send me that, please? Any questions? Let me just try and back the screen back.
I need to stop sharing my screen.
Yeah. Okay, great. All right, I recognize Member Juliet Holness and then Member Brownberg in that order. Member Holness? No? All right. Member Brownberg, you had your hand up.
Okay, thank you. Thank you very much. Just a couple of questions. I note we speak of a 1.6 positivity. Is it positivity? No, reproductivity. No, let me go back to the positivity. 6.1% positivity. And I wanted to just have an explanation as to what that means.
The positivity is the proportion of all the tests that are positive. So all the tests that are performed.
We hardly hear anything that is based on science or facts in terms of the things that should be concerning us. And I don't know if I have not been paying sufficient attention to it. It could be, but it would also mean that others might be in the same position. So I believe it is about time that we started to talk now about exactly what those figures mean and what are the, where we would want to see them and why.
I'm not clear on the issue about science and fact and what the figures mean, because we do speak about them almost weekly in terms of the meaning behind the figures. But if there's a specific area that you're not concerned about, I think Dr. Hamilton would be Wellington, sir.
No, Minister, I mentioned two in particular. And so I mentioned two in particular, and I'm hoping that you understood my question in that sense. I'm talking about the positivity and I'm talking about reproductivity. Those two in particular. I believe there are others that we have understood, but there are others that we have not paid as much attention as even the active cases. We understand what those are. We know what dead is. We know what positive is. So I'm just saying that those two in particular jump out at me.
Okay, Dr. Wellington, you want to comment on those two?
Well, beginning with the reproductive rate, the basic reproductive number, that gives an index of how transmissible, like how many persons, essentially one infected person is expected to transmit the disease to. If it is less than one, then it means that the number of cases will steadily go down to zero.
And if it is
greater than one, that means that we still have active transmission going on and the outbreak is being propagated.
What is the RO for COVID currently, the thinking?
It's a range. It was at roughly 3.4, but the range varies or has varied.
Why I asked is that there was a new report coming out of, I can't remember exactly where, that suggests that it is probably about 6.3. And refuting previous suggestions that it was about 3.7 or thereabout.
Okay.
No, but we would need to get some specific particulars on that before we conclude on that, member.
I think, but Dr. Wellington is aware of it. She nodded her head when I said that. So certainly I suspect that that could be had in the ministry, Minister.
I would not.
No, I just said I can't remember exactly where it was from.
Yeah, but just for the record, I would ask her to make a note of that.
Sure.
And we'll report back next time, not to accept the suggestion. We need to be clear on these things. So,
no, the suggestion was for her just to check on it, Minister.
Right, okay, for the record, right. We'll check on that.
Minister seems to know what she's thinking. Crazy.
Minister, I'm back.
No, Minister was wondering why I didn't allow the doctor to determine whether or not she had the information or not.
No, she indicated to me. She indicated to me.
Okay.
For the record, these things are correct. But I will say quickly that I do agree with you in one sense, Member Brownberg, and that is that we have to start placing greater emphasis on data that represents other indications of the virus outside of positives and negatives. Persons tend to focus how many more positive cases each day. And there is a sense that the success in coping with the virus is only determined by less positive cases. And I am prepared to say, at the risk of even being controversial, that the new norm that we must now move towards should envision a life with COVID, not without COVID, because it's unlikely we're going to get rid of COVID anytime soon until modern medicine catches up, whether through a vaccine or otherwise. So it really is, how do we manage the response and how do we mitigate against the risk in a way that minimizes death and minimizes downtime and minimizes the spread. So data, for example, that around death. The truth is we have done well. Our death rate is 1.7, I think 1.6 or 1.7 I saw yesterday, %, which by benchmark international standards is not bad. The last time I looked at the international standard was something like 2.8 or closer to 3%. Asymptomatic versus symptomatic. The truth is we have no one in ICU now or in high dependency units, which means all the persons that are now positive, none of them have life-threatening, at least for now, are critical. And that's important, because what it means is that you can overcome COVID. It's just to put certain mechanisms in place. And the hospital system, as of now, is not under stress. We have over 300 COVID beds. And I think less than half of those are occupied as we speak. Now, it's not to say we must be complacent, but it does give an indication as to how we're managing the process. But beyond that, we should also dissect the numbers to determine the extent, the vulnerabilities or the vulnerable groups. And that's where I think we need to focus. And I'm going to spend some time looking at this, even at this level of this committee, because the persons who are most threatened are going to be the persons who are most vulnerable. And we have to define what that vulnerability means and develop a tracking mechanism to track those vulnerable communities, as we have done with nursing homes and infirmaries and prisons. But there are several other vulnerabilities out there, underlying conditions, poverty, inner city communities, some of those things. So we have to move towards doing that and make those an indication of how we're managing the process. As a
Chairman.
Yes, Member Guy.
Yes, thank you very much. You had
Member Guy, my hand has been up.
No, man, mine was up and I was on, but Minister interrupted.
No, I
Member Guy, my hand was up prior to that. I was muted.
And I'm glad you did.
You actually interrupted Member Brown Burke, Member Guy, but
She yielded to me, Chairman.
She's yielding. Also, she's giving up her. All right, well, go ahead, and then after that, Member will come in.
I'm glad you mentioned the whole aspect of the new norm, and it takes us to the whole concept of the serology testing. Some time ago, you mentioned that the ministry was looking in this particular direction. Where are we now?
Dr. Wellington, you have anything to speak on that? Otherwise, we'll have to get some.
We'll have to consult with the lab.
All right.
Samples are being collected.
Samples are.
For the serology testing?
Yes.
Okay.
And maybe what I'll do, Member Guy, is have as one of our special guests in future meetings, if not the next one, the one after, the lab staff or leadership.
No, but we don't need them, Minister. It's a decision as to the ministry as to when you start doing serology testing. So the fact is that I'm just wanting an update, because some time ago in the meeting, there was an indication that we would move into a different type of testing as well. So I'm just asking for an update on that. Where are we now, particularly in light of the fact that you mentioned that we have to looking at living with COVID. And certainly this is one of the recommended testing that is done.
All right, I was speaking more generally, but point taken, and we make a note of that. Member Holt.
No, Minister, sorry.
You're not finished yet? Okay, go ahead.
No, not finished. Might I suggest, and we speak of the death rate, and I'm happy that we are at 1.7 percent. Could I, however, Minister, make a suggestion, which I would like to record it as well, that we do not fall into the position that Russia felt it had? And could I recommend to the ministry that we look at the death rates for the period last year and compare to this year to see whether we might be having persons who might have died and not recorded as having COVID, and to have a comparison to see whether with this superimposition of the pandemic that there are deaths there that are not recorded as a consequence of COVID. We might not have, we will not have a precise answer, but at least we'll have a feel as to what might have happened comparing last year this time, or the last 2-3 years this time with this year this time.
Look at the numbers of deaths.
Yes, through the RGE to find number of deaths. This is why I said the Russian experience is that they thought they were doing good until they recognized that there were a significant thousand number of deaths that they were having in the country, greater than the period they had for the succeeding or the previous years.
I have no problem with that, member. Just to reiterate that we're not being complacent at all. In fact, we're taking actions that sometimes attract criticisms because we are very cautious in terms of what we do. But
there was never a suggestion, Minister. I was just saying that for us to be complete.
All right. Any other point, or should I move on now?
Later on, I'll allow you to have.
Oh, you want to go ahead now?
Minister or Chairman, and to our doctor as well. Is there any mechanism we can use in terms of statistics to have in a very sharp way, Jamaicans being minded of the difference in our statistics if they wear their mask and continue to follow the necessary protocols, vis-a-vis not doing so, what the difference in our numbers will be going forward? Is there any sort of statistics that we can?
Okay, I'm going to ask Dr. Wellington to respond to that. Go ahead.
Thank you for the question. We're actually in the epidemiology team is actually in the process of reviewing different models that would look at the effect of different interventions. And I take your point that something visual may be very effective. So not the statistics as well as showing the difference that the different interventions, for example, mask wearing, would make. So we're in the process of reviewing the different models to see which one would be the best fit for our situation.
Okay. What's the timeline on that, do you think? Is there a period of time that you think this can be exposed, or
we can provide an update at the next.
Okay, we'll follow up on that. Member Golden, Member Holness, any additional follow up to that, or no? All right, Member Norman Dunn, you have your hand up.
Thank you very much, Chairman. It will be remiss of me not to make a comment about Southeast St. Mary's, in that we have been quarantined with a day or so left to go. I'd just like to place on record my appreciation as the Member of Parliament for the quick response that the ministry did in order to quarantine the area, and the subsequent intervention by the healthcare team, and you in particular, Minister, Chairman, who has been on the ground. The persons, I can tell you, are very appreciative, and I like that to be placed on record. However, during that time, there was one issue that I believe going forward for areas that are going to be on a quarantine that we could look at, and that is the aspect of communication as it relates to adjoining communities that might be affected during the quarantine process. So at least we recognize that there was a little issue in that area, and we could make adjustments as we go forward. So that's a comment. The questions are, one, with the opening coming up on the 1st of June, will technology be an important part of this new normal living with COVID? And if so, how are we in preparing the technology for that? That's number one. Number two, in recent days, we're very optimistic that we have had two period of reporting in a very short time of no new case. Is this something from the epidemiological point of view? Is this something that we can see happening on the horizon, or is it too early to make an assessment of that? So those are the comments and the questions.
Okay, well, first of all, thank you very much for the comments as it relates to the healthcare team, and I accept on their behalf and reiterate what you have said, that they have really done an amazing job, as the case is in the other areas that have been quarantined. I think our strength definitely lies in our contact tracers on the ground, who are our public health officers, public health nurses, community health aides. And thanks to the community too for their cooperation in responding to the team, and to your leadership too, Member of Parliament, and the councillors and the mayor and all those in St. Mary, because I think it was truly a giant effort, and we appreciate that. And if we get that kind of effort going forward, I think we can overcome the severity of the risk associated with COVID. As it relates to the questions, I'm going to ask Dr. Wellington to quickly, any comments on the questions asked, the two questions, quickly.
So the final question first, regarding the zero, having no cases reported on any given day. It is too early for us to say, and that's one of the reasons for us exploring modeling and forecasting to get a better picture. Although, modeling is fraught with uncertainty, but it's too early to say whether or not it's time to celebrate.
Can I come in here and say more definitively, it is no time to celebrate at this point in time. We must be encouraged, we must remain motivated, but we must be steadfast, focused, and never get complacent, certainly not for the time being. The reality of the situation is that the team has done well. The collaboration, the coordination, the response in contact tracing, in managing the process. And so we must be encouraged and take some comfort in that fact, because we're seeing the manifestations of that in the numbers. However, we are about to embark, or are embarking, on a gradual reopening of our environment, which is expected and, frankly speaking, is needed. And that in and of itself, that exercise, as gradual as it is, or may be, is going to represent a new set of threats to the population. Once your airports and seaports starts opening up, persons starts coming in, once you relax some of the stringent measures of institutional quarantining and begin to move to home quarantining, where the management and the coordination of that becomes more difficult, where persons have to depend on self-discipline and many may not be as disciplined, then the truth is you're going to see another set of threats that could affect us if we are not very vigilant. Now we're responding to that with the expansion of our teams in the field, training, hospital preparation, and so on. So we are trying to balance the risks or the threats with the response. But it certainly is not a time for us to celebrate the end of COVID. That's why we latch on to the theme of living with COVID, because we think that represents a more realistic expectation going forward. What's the other question? What was the other? Quick.
Technology. How much will technology be featured in the new norm of living with COVID?
It's going to be a substantial feature in the new norm, member. In fact, we're now going through you would have seen some of the apps that have been advertised, the jamcovid19.com, but there are other things that are coming on board that will be introduced soon. We have gadgets that not only will use the mobile phone to locate persons or to track movement in terms of COVID management, but there are others that will be special devices that would be linked to an individual that will be used and managed remotely solely around the COVID response. So there's a tracking device equivalent to a watch, I think you a watch or something you put place on your body, your hand, and that will provide some monitoring, just as it relates to the COVID and home quarantine. You know. More will be said on that in the future, but technology is key as it relates to the institutions, the hospitals and health centers. We are now moving into a phase of health information system, which will link the respective institutions, including labs, that will also provide benefits to the pace of responsiveness around COVID, but also around other issues in public health. So we do see technology as a critical part of moving forward. Member. All right, thank you for that. Member Guy, is it that your hand was always up or your
No, it came down and went back up, Minister.
Oh, okay. Quick, can you go ahead?
I noticed that in the just recently put up slide, we had 18 cases in St. Mary, and one is from the Scottsall area, which was never featured in any of the discussion so far. I just want to know, in terms of that one positive case coming from that area, whether the health team is in that area doing the contact tracing for that positive case that has been found. I hear the mention of the work in the Dover, Enfield, and Otter Bay area, Minister, but with this one particular case, can you advise us to what is happening in terms of contact tracing there? That's one.
I don't know if Dr. Hamilton has any response on that, or we'll have to check. Normally,
Wellington.
Dr. Wellington, sorry, Dr. Wellington, anything on that?
The standard procedure is that once a confirmed case has been identified, the health department would initiate contact tracing and take the relevant actions around that case.
Okay.
So for every confirmed case, contact tracing is carried out.
All right. Minister, there are two other general questions I want, not specific to the presentation.
Okay.
Okay.
Go ahead, member.
Yes, there are two questions. Is there currently a shortage of PPEs in the facilities across the country, the hospitals and health centers or health facilities?
Not that I'm aware of, generally speaking. There are times when we run low on certain types of PPEs. So the face shield has been a very consistent low supply item. Whenever I go out, I'm told that they have limited numbers. Not that it's absent, but the numbers are limited. And I'm told by NHF that they're having difficulties sourcing the face shield. We're making some locally, but that has been a fairly consistent item identified as being short or low supply levels. I can't say that I've gotten, I think that probably represents the most significant one. Beyond that, I know the NHF manages the ordering and restocking process, and they maintain a direct link with the regions and do the supplies there. If there are issues, those issues, we try to deal with those issues immediately. So it's you know, you do have times when reports are made around low stock, and we try to deal with them as quickly as possible.
All right, Minister, the other one, there is a report coming out of the United States about the FDA's report of K95 masks, which have been found not suitable. Have we, unfortunately, been the beneficiary of any of these masks that they have cited the manufacturers as not bringing the stuff up to standard?
I would need to check on that. What I have not been told that any of our masks are not able to be used. I don't know if any have been defective, but I can find out. I mean, the NHF manages the sourcing of those items, so I'd have to find out, and I could get back to you on that.
And another one as it relates to NHF, Minister, can you say whether NHF in sourcing masks have relied on the any local dealership here to get masks from them or through them?
In the early stages, as I understand it, and we can get more particulars on it, everything was in short supply. That was when everybody was demanding PPEs, and we were having a lot of issues, as you know. And NHF was mandated to source wherever they can, and because they are experienced in sourcing, because they buy the drugs and other things. I believe they have sourced through multiple sources, and some perhaps, I'm sure some would be local, and others overseas. But it was really a case of trying to just get where they can get, because it was just difficult. And I'm sure there are margins of error in that approach to sourcing. In the more recent times, I think they have settled down, and because supplies are more available, both in terms of manufacturing source, but just the logistics of moving products. So we're overcoming that. I mean, if the committee wishes, I could ask Everton Anderson, Mr. Anderson, to appear and to have a conversation around supply shortage.
I would like that, Minister.
Yeah, we can arrange that. That's not a problem.
Minister.
Yes.
Well, this is a matter that relates to just a organizational matter as it relates to Bahia Principe, in that there are still complaints coming out of in terms of the medical treatment for some persons who would have arrived and do not have medication. Only this morning I got a call from one of the recently repatriated person about being out of medication from Friday, and the medical personnel being advised and committed to get on up to this morning was only the first time that she got her hypertensive medication. And you know, it is just this is just one case that could be either one or of many. So it's something I'm asking you to have your team look into to ensure it does happen again.
Point taken. Thank you. Thank you, member. Okay, so I'm going to thank Dr. Wellington for her presentation. It's now 11:48. I was wondering if I could quickly run through this prison
Awesome.
corrections, or you wanted to wait until next time? Next time?
Yes.
Okay, fair enough. All right, any other business?
Well, Minister, just you did a while ago, but I just want also from our side to thank Dr. Wellington too. The presentation was lucid, quite clear, and of the level that we would have expected from the epidemiologist.
Thank you.
Thank you very much, member. She appreciates that compliment and recognition.
Thank you.
Any other item? Any other matter? No, I know it's a busy day for parliamentarians. Okay, if not, let me just take the opportunity to thank you. Our next meeting hopefully will be a similar time next week, but the parliament will be in touch to indicate. Thank you very much and have a good day.
Minister, I think we can't have next week at this time because the PAC meets on that date, from my recollection.
Okay, well, we'll look at the dates and see what date is available and then move.
So moved.
Thank you, member Guy, seconded by member Dunn. Thank you very much. Meeting adjourned. Thank you.
I didn't want to block the camera.
That's fine.
You know what I'm here thinking about?